Hi, today I'll be talking about reducing emergency department overcrowding using a patient discharge lounge. So first I'll talk about my change theory, which is Lippitt's change theory. So it's basically to add pi for the problem, which help direct the steps of the project. And my peacock question is, in a hospital within Southern California, how would the use of a discharge lounge versus the standard practice of discharge, which is waiting in a hospital room, affect ED admission process time as well as discharge process time over a 6-month period, which is January 2023 to July 2023. So for the identification and significance of the problem, with increasing life expectancy and chronic degenerative diseases, ED overcrowding is a significant issue for health systems worldwide. It demonstrates an imbalance between the supply and demand of hospital resources, leading to ED overcrowding. And this results to longer admission process time, decreased patient satisfaction, delays in medical treatment and patient recovery, increased adverse events, increased morbidity and mortality rates, both in children and adults, increased number of patients without leaving without being seen, and higher operational costs and loss of revenue for the hospital. When ED is full, we essentially close our doors to the community because this is the gateway into getting into the hospital if there's no scheduled appointments. My plan change project is the patient discharge lounge, and the factors that will enhance the change project is staff adherence and stakeholder buy-in, which is basically the hospital administration and the patient's support. And factors that hinder the change is lack of support from stakeholders and the staff. So the lit review and the summary of evidence. The databases I use is PubMed, CINAHL, and Clinical Key. The key terms I use is emergency department overcrowding and patient discharge lounge. So Bittencourt et al. Discuss 4 interventions combating ED overcrowding, which is strengthening triage service, strengthening ED staff, creation of new care units, and a change in ED work processes. Sartani et al. And Salvioli et al. Examine factors that affect patient flow in input, throughput, and output, as well as micro-level and macro-level strategies in combating ED overcrowding. McKenna et al. Considers ED overcrowding as an institutional-wide lack of inpatient bed capacity and provides solutions similar to the macro-level strategies specified by Sartani et al. And Salvioli et al. And here in the table, we can see that the macro-level strategies are applied to the ED department, which is acceleration of diagnostic pathways, fast track, outpatient services outside of the ED, setting a home care observational unit, and strengthening the triage team. And micro-level strategies are strategies applied at the hospital or a healthcare system level. So this can be reverse triage, smoothing elective admissions, early and weekend discharges, and having like a full capacity plan or action plan. So for my patient discharge lounge, it uses 2 or 3 macro level strategies, which is reverse triage and early and weekend discharges. So continuing on with the lit review, Nassar Isfahani found that the DL is an effective intervention for ED overcrowding as it increases bed capacity, as well as improve the discharge process and patient flow. Franklin et al. Found that the increase in discharge lounge utilization results in a decrease in the discharge process time. Rhodes et al. Found that the use of a discharge lounge results in higher patient satisfaction, increase in early discharges, reduced boarding time, decreased 30-day readmission occurrences, and improve patient safety and quality of care. Woods et al. Found that an increase in staff education, a DL dedicated staff, and visual cues for the discharge orders help increase the DL use and effectiveness, which is basically the utilization rate. So possible solutions for ED overcrowding is number one, expanding the ED capacity by expanding the ED unit. The pros for this is more patients are admitted and seen. The cons for this is that it increases capacity of boarded patients, nursing staff is more overwhelmed, and this needs an increase in space. And this is actually the least effective as patients are only seen, but they're not treated. Solution number two is establishing an acute medical unit. So more patients are admitted and seen, and more patients are treated because there's more inpatient beds. However, this is unattainable short-term due to legality and logistics. It's also hard to find a full nursing staff and associate staff on short notice, and space and maintenance is needed. And however, this is slightly more effective than the first one because there's more inpatient beds. Solution number three is the plan change project, the discharge lounge. The pros for this is that there's a decrease in the discharge and admission processing time. The boarding time is also reduced by increasing the bed capacity. There's a higher patient satisfaction. There's increased in early discharges, and there's a decrease of 30-day readmission rates if they use the discharge lounge as an additional educational tool. The cons for this is that there's a need for a specific space for the discharge lounge. There's also the need of support from the nursing staff and the stakeholders and prioritization of the clinician's time, which because of the early discharges, are they going to do rounding first or are they going to do discharge first? That's one of this one problem for the physicians. And then for the nurses, they need a person running and preparing the patients for the discharge lounge, as well as their regular workload. The expected results of the plan change project is the decrease in patient discharge process time, decrease in ED admission process time, and increased bed turnover, which is increasing the bed capacity. And this is the most effective and the recommended best practice based on the literature I've read. Implementation of the plan change project, which is the discharge lounge. So here we can see how it's outlined. There's a pre-operational phase, which is basically setting up the discharge lounge, and then the operational phase, which is using the discharge lounge. And this will be seen in the protocol later. The action and policy of the discharge lounge is that if the patient's discharge process time is delayed more than 120 minutes due to the transportation delay to home, the patient will be transported to the discharge lounge to wait for pickup. And then here in the figure below, we can see that how the discharge lounge affect patient flow. So if there's no discharge lounge, the patient will just be waiting in the inpatient bed, and the next patient will be just waiting in the ED bed. However, if we move them both with a discharge lounge, the ED patient that's being aborted can move to the inpatient bed, and patient number 3 will be quickly more seen because we want the first patient to be transported within 120 minutes. Then here's the protocol and the inclusion-exclusion criteria for the discharge lounge. So first we do a 24-hour reverse triage to see who's the most stable patient to be sent home, or which patients are stable enough to be sent home. And then when we receive the discharge order, we remind the patient and the caregivers about the discharge processes, and introduce the discharge lounge as well. Patient care, meals, and scheduled medications will be given before leaving the nursing unit. And when the patient discharge is anticipated to have a delay of more than 120 minutes due to transportation, the patient will be screened for eligibility of the discharge lounge. And if the patient is eligible, the patient will be billed by the nurse aid, or patient transport to the discharge lounge where they wait for pickup. And then the inclusion criteria is they have to be an adult, age 18 or older, and you have to have a discharge order from the physician. They also need to be alert and oriented. They need to have their medication ordered and released to the outpatient pharmacy. Patients with diabetes requiring glucometer checks will have their blood sugar checked with appropriate follow-up and diet prior to leaving the nursing unit. And patient can sit in a chair for prolonged periods and is ambulatory and capable of self-care. Transportation arrangements need to be made to arrive up to 6 p.m. The exclusion criteria is that patients are being transported to another facility, patients having been on isolation precautions, patients that are confused or have any form of dementia, patients with documented high fall risk within the previous 24 hours, psychiatric patients, patients being discharged for hospice, patients requiring any type of treatment such as suctioning, oxygen, and continuous IV, and any other conditions or care needs that needs to be monitored and are not appropriate for home. Evaluation of the plan action. So first, we looked at the results of the plan. After the discharge launch implementation, there was a decrease in admission and process time. And then evaluation of the plan, which is for its effectiveness, we looked at this admission process time and discharge process time. We didn't have data on utilization rate of the discharge launch, but you can also use length of stay or bed turnover rate. And in this data, it will be collected by the project manager with the help of each unit's secretary or nurse manager. What facilitated the change is informational flyers, emails, informational meetings and huddles, staff education and patient eligibility, and notifying staff when DC order was written. Tracking progress and relaying information to the staff. What inhibited the change is staff hesitancy, low utilization of the discharge lounge, and prioritization of the clinician's time. So this slide is about the results of the discharge lounge after implementation. Here we can see that the discharge processing time has been halved from about 2 hours and a half to less than an hour, while the discharge process time only decreased by 40 minutes, which is still significant. But in other units, because this is just the hospital average, there are patients that are waiting for pickup for 300 to 400 minutes. So reducing it to less than 120 is also significant. And then future implications of the planned action. So first, we had feedback from the staff, which is that the discharge lounge has shown the need for amenities such as food, snacks, recliners, and possible permanent staffing, at least one licensed vocational nurse or a certified nurse aide. The use of a discharge lounge not only reduced admission and discharge process time, but it also was able to help improve a more efficient discharge process, as well as enhance the quality of patient care and safety received by the patient. Instead of the discharge lounge being used as only a waiting area, it could also be used to increase patient education, schedule follow-up appointments, and address any last-minute medication or equipment concerns. And then here are my references. Thank you.